Good morning, everybody. Thank you, chairpersons. Much of my job has been done by Professor Sandeep Bansal already. So I'll try and give you some crisp take-home message as how to go about, because most of the introductions about viability and associated trials have been spoken about by Dr. Bansal. So in the field of chronic coronary syndrome, these are some of the landmark trials that have happened in the new millennium. So in the first half, we had Courage, Bari, 2D, Stitch. That is the subject of one of the subject of my talk. Then to follow it up, we had more defining trials like ischemia, FAME2, Orbita, and then we had various follow-up studies of Stitch, the long-term follow-up, the Stitch viability studies, and so on, which were published later. And very recently, in 2022, we have had the revived BCI S2 trial and the FAME2 trial. And based on this, we have had some of the guidelines, the ESC, ESCTS guidelines on myocardial revascularization, ESC guidelines on chronic coronary syndrome, and ACC/AHA SKY guidelines, again on myocardial revascularization. So why are we talking about addressing this kind of contentious issue like viable myocardium and subjecting the patient to PCI? This is because of the tremendous advancement in the field of PCI that has taken place, starting from the study of coronary physiology, the FFR and its various other recent advancements, the IFR and so on, then non-invasive imaging of the coronary arteries, then of course the intravascular imaging, IVAS, OCT, and so on. So all these have contributed to tremendous improvement in PCI outcomes. So we have become more adventurous and now thinking of addressing very ischemic LV dysfunction. So this is the study that I'm going to present in little bit details and then talk about its perspective in view of the other trials, the REVIVE trial, presented in the last ESC 2022. What was the background? Whether revascularization by PCI can improve event-free survival and left ventricular function in patients with severe ischemic left ventricular systolic dysfunction as compared with optimal medical therapy, that is individually adjusted pharmacologic and device therapy for heart failure alone is unknown. So this was the design. LVF was less than 35%. Viability was studied by all the modalities that Dr. Bansal has mentioned on CMR, DSE, SPECT, or PET. So it was a very state-of-the-art assessment of the viable myocardium. PCI feasible to lesions subtending more than equal to 4 dysfunctional but viable segments was carried out, and then the patients were randomized either to the state-of-the-art PCI or to optimal medical therapy. Optimal medical therapy was also state-of-the-art, as I'm going to show you. Echocardiography at 6 months and 12 months, and the clinical biochemical follow-ups were done at 6 months, 12 months, and 24 months. So it was not a very long follow-up. It was mostly 2 years or about so. But then there was no difference. We had 129 events in the PCI group, 37% of patients, and OMT 134 events, 38% of patients. So there was absolutely no difference in outcomes in the two arms, PCI versus OMT. And if you consider the subgroups, there are some interesting trends, but none were very definitive. You see younger patients tended to fare better with PCI. The BCI Jeopardy score, the more the score, the results were somewhat better with PCI. The worse the EF, again, little better with PCI, but not significant. Diabetes did not matter. Functional class, we did not have too many patients in NYHA 3-4, which was a fact, but then there was no difference. AF did not matter. Left main, very importantly, if you had left main, then doing PCI in such patients did have a poor result. So that is a point to be noted. And again, NT-proBNP values did not matter. So overall conclusion, among patients with severe ischemic LV systolic dysfunction who received OMT revascularization by PCI did not result in a lower incidence of death from any cause or hospitalization for heart failure. So these are some of these trials have been mentioned by Dr. Bansal already, the heart, part 2, and stitch, and then the latest revived BCI S2. So, the primary outcomes were variable. So, stitch, revived, and heart considered all-cause mortality, the hardest of endpoints. Part 2 had more of a composite outcome of CV death, MI, hospital admission due to cardiac cause. But revived also considered hospitalization for heart failure because these patients had severe LV systolic dysfunction. There were several secondary outcomes, more so in the recent revived change in NT-proBNP and unplanned revascularization were some of them. So, and then the quality of life scores, very important. That was also considered in revived BCIS2. Inclusion criteria, all trials included very dysfunctional patients, LVEF in all were less than 35%. Heart insisted on more than equal to 5 viable segments. Then part 2 had more a varied kind of inclusion criteria. Stitch did not depend on viability at all. So, whenever the coronary anatomy was suitable for revascularization, it was done. And revived BCIS2, had a more stringent criteria, as I mentioned, that they needed to have 4 dysfunctional myocardial segments amenable to revascularization with PCI. And then people with acute coronary syndromes and other diseases needing surgery like aortic disease, cardiogenic shock, blah, 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 were excluded. I'm not going into that. So LVEF on an average was less than 30%. So very sick patients. As I said, of all these studies, the revived BCIS2 had all the modalities that were studied. So it was a comprehensive viability study technique that was taken up in revived BCIS2. So all these studies were more or less 5 years, but except revived BCIS2 where it was even less than 2 years, you can see 41 months was the mean follow-up. So very short-term follow-up, and that is one of the drawbacks or limitations of the revived BCIS trial. Now, when it comes to outcome, one thing is common: no significant benefit of revascularization of our OMT in the short-term period of 5 years. So stitch only showed benefit when the 10-year follow-up results were considered. It showed a lower all-cause mortality than OMT. Revived BCIS2, again, overall same conclusions. But you see, as I'm going to show, somewhat better quality of life that is to be considered. But then whatever was there, quality of life improvement tended to disappear beyond 24 months of follow-up. So these are the trials side by side. And this again beautifully shows the impact of impact of viability-guided management on all-cause and cardiac mortality in RCTs of patients with ischemic cardiomyopathy. You see more or less neutral. It does not provide any benefit except for a subgroup of part 2, which showed that study of viability does matter. But part 2 overall was a very small trial. You can have a look at the number of patients that were included in this subgroup, very small subgroup. So this is a kind of a master slide. You see we have 3 variables: viability, prognosis, and functional recovery, that is improvement in LV function. So you see the dotted lines means conflicting data. The solid lines means well supported, and the red solid line means RCT demonstrates no association. So overall stitch viability showed somewhat improvement in prognosis. But whenever revascularization was done, it was very, very doubtful. But overall, in the 10-year period, when CABG did show a reduction in all-cause mortality. And then overall viability and functional recovery, no. It does not. So functional recovery does not occur, but patients somehow at the end of 10 years with CABG in stitch trial live longer. Christmas trial, but was a medical therapy trial with carvedilol. It did show that if there was viable segment, if you treat patients with carvedilol, patients can have an improvement in ejection fraction. In fact, beta blockers were the first group of drugs which showed an improvement in ejection fraction. And then functional improvement, better the ejection fraction, the better the prognosis, is something that we all know. And then coming to the STICH viability sub-study 10-year outcome data. So it mostly banked on SPECT, and you see medical therapy alone and medical therapy plus CABG. When these groups are concerned, overall, in terms of demonstration of viability, I mean, no significant difference in the hazard ratio, but with viable myocardium, you can see that patients tended to do better with medical therapy plus CABG compared to medical therapy alone. So if you do revascularization with viable myocardium at the end of 10 years, you do benefit from CABG. So that was the outcome of the subgroup study, that is STICH viability sub-study. So a side-by-side comments, you see patients with STICH were treated at the state-of-the-art OMT at that point of time. So ACE inhibitors, beta blockers, and digitalis. Now, in revived BCIs, patients were treated with ARNI. You see 29%, I mean, almost 30% receives ARNI. MRAs, which were not used in STICH, were used, and beta blockers were, of course, used along with ACE inhibitors. So patients in revived received better treatment. Of course, SGLT2 were not used still in revived trial. Now, another drawback of revived when compared to STICH, I mean limitation, is that less symptomatic patients were included in revived, and whereas in STICH trial, almost 43% of patients in STICH had CCS class 2 angina. Such patients were not included in PCI-BCS2. So it's a point to be noted. So unless you include patients with symptoms, how can you look for benefit? So that is one of the drawbacks of revived PCI-S2. On the other hand, revived included older patients with a mean age of 70 and 69 years in PCI and OMT groups, whereas in STICH, there were younger patients, less than 60 years. So these are the points to be noted when we say that CABG is better and PCI is not. So although overall results lead to a conclusion of no added value of PCI over OMT in patients with coronary artery disease and reduced LVEF, there are at least 3 issues that may be taken into account when interpreting the REVIVE trial. First of all, well, we have only studied till 41 months. So we really do not know what is going to happen at 5 years and 10 years. But already we know there were lesser incidents of VTVF terminated by ICD in the patients who had ICD. So of course we can, hope that these patients should tend to live longer with PCI when done properly. Then mirroring what we could see in the ischemia and FAME2 trial, the rate of spontaneous MI seems to be decreasing over time in patients who underwent PCI as opposed to OMT alone. So in addition, as expected, the rate of unplanned revascularization was reduced in the PCI arm. And third, as pointed out in an article in NEJM, a degree of selection bias could not be entirely ruled out, as some patients potentially profiting from revascularization may have been diverted towards surgery before being considered for trial enrollment. So these were another drawback. So in addition, 2/3 of patients had no angina on baseline, and the decision to revascularize was preconceived by the existence of myocardial viability, which in the STICH trial did not have an impact on the effect of surgical revascularization and mortality. So these are the modalities, the types of kind of ischemic LV that we know. So stunning, early hibernation, advanced hibernation, and infarction. And you know how it matters in terms of contractile reserve, glucose metabolism, extracellular volume, and so on. And these are the various methods, again, highlighted by Dr. Bansal. So SPECT, targeting membrane integrity, CMR, extracellular volume, DAC on contractile reserve, and PET on glucose metabolism. So the conclusion, which also Dr. Bansal has highlighted, viable myocardium should not be considered as a single entity, but as a spectrum, including jeopardized, stunned, early hibernation, and advanced hibernation, the revascularization of which may yield different pathophysiological benefits. For patients with ischemic LV dysfunction, the question is not whether they have viable myocardium, but how much they have of each type, where it is, whether it is likely to recover, and how long this may take. So these are the crucial questions to be asked. So this is a master algorithm that I would like to present to the audience. So managing patients with ischemic cardiomyopathy, anginal patients, if no, look for significant myocardial hibernating myocardium, at least more than 7% studied by PET or CMR? If yes, go straight for CABG on top of OMT to improve prognosis. If not, go for a heart team evaluation, consider CABG. If low surgical risk, Euroscore 2 less than 4%, consider PCI in selected cases according to syntax score. If anginal symptoms are there and there is significant inducible ischemia more than 15% of the LV, yes, again straight away go for CABG on top of OMT. If no, again heart team evaluation, CABG for low surgical risk, Euroscore 2 less than 4%, PCI in case of refractory symptoms if CABG is not indicated or refused. So the concluding remarks, until newer and more relevant evidence emerges, surgical revascularization, when technically feasible, after carefully weighing of the perioperative risk, would appear to be the best option for selected patients with ischemic cardiomyopathy. Such an approach also has been reported to be cost-effective over OMT. Viability or ischemia testing appears not to be mandatory based on current evidence. Documentation of viability today possible at its best with CMRI or PET would, please note, would still appear, however, a logical step, no matter if not based on strict evidence, but with the aim of tilting the balance in favor of surgery in cases where perioperative risk makes decision particularly difficult. And then conversely, the practical impact of ischemia testing on clinical decision-making, particularly in the absence of ischemic symptoms, would appear less robust, although in recent retrospective evidence in patients not selected for LV ejection fraction suggests a possible benefit of ischemia-guided revascularization in the presence of a very severe ischemic burden, that is more than 15% of LV myocardial, as I showed, based on SPECT. Such data, of course, need further confirmation in dedicated RCTs. So considering the recent results of REVIVED BCI-S2 trial, indications to PCI in patients with ischemic cardiomyopathy would remain limited to patients in whom ischemia-related symptoms such as angina are refractory to OMT and predominant over heart failure-related symptoms. Thank you very much for your patient hearing.